Hello, everyone. I'm Dr. Catherine Tuttle. I'm a professor of medicine at the University of Washington and executive director for research at Providence Healthcare. I'm also chair of the ASN's Diabetic Kidney Disease Collaborative, and it's my great pleasure to welcome you today to the second strategy conference, in which 2 keynote presentations will be followed by breakout sessions, which we invite all of you to join for rich conversation and collaboration on 5 key questions. I would also like to acknowledge the support of the Diabetic Kidney Disease Collaborative by Bayer, Boehringer Ingelheim and Lilly, AstraZeneca, and Janssen Pharmaceuticals. Here is our agenda for today. Following opening remarks, you will hear from Jay Shubrook, who will give the primary care perspective on awareness, detection, intervention. Joshua Newmiller had planned to give the talk on implementing best practices, but an urgent issue came up, so I will be stepping in on his behalf today. Following these presentations, we will have breakout sessions from Dr. Chip Brocious and then breakout session reports, followed by a wrap-up with a call to action. Today's opening remarks will be given by Dr. Amy Model, Associate Professor of Medicine in the Division of Nephrology and Hypertension at the University of North Carolina School of Medicine. And as I mentioned, the breakout sessions will be introduced by Dr. Chip Brocious, who's Professor of Medicine at the University of Arizona. And then finally, Dr. Christos Agaropoulos, Chief of Nephrology and Professor of Medicine at the University of New Mexico School of Medicine, will offer closing remarks. And finally, in the spirit of the changing nature of medical information and practice, particularly during a pandemic, please note this disclaimer that this is for information and educational purposes and should not be construed as offering specific medical or advice or recommendations for patients. So with that, thank you very much, and let's get started with Dr. Model.
Good afternoon. Thank you so much. It is truly a pleasure to be here with you today. You know, I've been a nephrologist for 15 years and counting, and I've really focused my clinical and research careers in diabetes and vascular complications with a main focus in diabetic kidney disease. And I've seen my patients really left far behind for a long time. And so it is so exciting for me to be in the field at this moment, because all of the novel therapies for diabetes and kidney disease in particular have really brought about a watershed for the care of this very important population. And this is really perfectly timed, I would say, because we're also trying to overhaul our approach to patient care in general, you know, with accountable care organizations and value-based care, and most importantly, patient-centered care. This is the perfect time for us to really care for providers who are on the front line, seeing these patients and identifying them. And so we have to work together with primary care, as well as all of the subspecialists and support providers as well, to properly care for patients with diabetes and chronic kidney disease. So I have also had the privilege of co-leading, and here are my disclosures. So co-leading the ASN DKD education module, which is a project in progress as we speak. Christos Agaropoulos is co-leading this with me, along with a host of very talented and broadly disciplined experts in diabetes and kidney disease. And here is the committee as it stands. And we have representation not only from nephrology, but also from endocrinology, cardiology, primary care, experts in obesity and nutrition, as well as pharmacology. And so we're very excited to bring this about over the next several months as an educational tool for providers, both in nephrology as well as other subspecialties and in primary care. And so these are the educational module topics that will be covered. including early diabetic kidney disease, again, diet, exercise, and weight management, which I think really nephrologists also need to become experts in, along with primary care providers and endocrinologists. We can't talk about diabetes and kidney disease without talking about racial and socioeconomic disparities and the importance of the primary care provider and multidisciplinary care. Of course, we will also talk about the important factors such as glycemic targets, the novel therapies that are anti-hyperglycemic agents in origin, but now we know are also cardiovascular and kidney therapies. We'll touch on proteinuria, hypertension, controversial issues in RAS blockade, cardiovascular management, and some of the less talked about but equally important issues such as what to do with acute kidney injury, which we know is so common in diabetes and kidney disease, and also nephrotic syndrome and the role of the kidney biopsy. So really, when I think about what the purpose of this educational module is, I think of it in terms of 4 realms. One is education, of course, to inform primary care providers and subspecialists alike about the importance of diabetic kidney disease and how heterogeneous it is and the best practices that we should all be following. To also offer some perspective and underscore the importance of putting the patient front and center. And then thirdly, action. As Dr. Tuttle said, this is our time to act because this is such an exciting, innovative time in this field. And we really need to increase the screening for diabetic kidney disease, patient education, when to refer, and most importantly, I think, is how to interact between providers, because these patients have multiple providers and we all need to be in communication. And historically, let's be honest, our healthcare model has not really provided for this, and we need to change that. And then lastly, cultural change, promoting that collaborative care amongst providers. So now I'll end there and I have the pleasure of introducing Dr. Jay Shubrook, who is a board certified family physician and fellowship trained diabetologist. He serves as professor of primary care at Touro University, California, and as director of clinical research and diabetes at his home institution. Jay?
Thank you, Dr. Model. It's a pleasure to be here today. It's a pleasure to be with everyone. These are my disclosures. And again, I hope that these are not going to be relevant to what we're talking about today. What I really hope to do today is to kind of pull it all together and so that we have a good handle on what our challenges are going to be if we're going to operationalize this, one, in a patient-centered manner, and two, through the lens of primary care, who sees the majority of people with diabetes and diabetes kidney disease. So I hope that I will not be a bummer, but I'll bring in kind of the perspective of the challenge that we currently have. And I'm surrounded today by many experts in the field, and I'm delighted to be part of this. So from a primary care lens, we know that nearly 1 in 10 adults have diabetes. It's 34 million adults, and it's even higher as you age. And so this is true for a quarter of our older adults. And if that was going to make us worried, well, a third of Americans have prediabetes and 73% of Americans are overweight or obese. So I don't think this is going away anytime soon. And we know that around 85% of people with diabetes get their care in the primary care setting. And so if we're going to implement something that's a change in the system, we've got to do it where most of our patients with diabetes are. And one of the things I hope we take from this today, and I was able to see patients this morning, is I always ask my patients, who's on your diabetes team? And your diabetes team is different for every person, but it's particularly as it relates to complications, a diabetes team is important. And I hope I highlight that. Now, in relation to diabetic kidney disease, we know that not everyone gets diabetic kidney disease, right? We've made progress. We see that only about 37% of people with diabetes will have diabetes-related kidney disease. And so that, in some respects, I guess, is progress. But because of the incredible increase in the rate of number of people who have diabetes, we're seeing an increase in the number of people with diabetic kidney disease. So, progress on one front, but we're actually struggling on another. And then I would also highlight that one of the challenges of being able to address diabetic kidney disease is that very few people know they have it. And so it's hard to act upon something you don't know. And this is the example I'm giving you is only 25% of people with stage 3 or stage 4 diabetic kidney disease know they have it. So this is not arbitrary kidney disease, this is substantial kidney disease. So let's take it back and what makes this so challenging. And again, having the luxury of been both in primary care and in diabetes specialty care, I've been able to see a lot of different things that I think hopefully will make it easier for us to make meaningful changes in our approach to diabetic kidney disease. Rarely do patients in primary care, come in for a diabetes recheck or a kidney disease recheck. They come in with a chief complaint. We've created a system that is illness-based care. And so people come in particularly for that. In fact, I've had patients say, I don't want to waste my money for a recheck. I want to bring money in. I'm going to come in when I have a problem. So that's a challenge. And again, even if they do come in and we're going to do a chronic disease recheck when they have a chief complaint, now we have competing agendas. Many providers and many patients see our chronic conditions as separate and unrelated to each other. Hypertension, dyslipidemia, fatty liver, heart disease, kidney disease. And that integration is not always obvious to the provider or the patient, which makes it hard to understand why these things are so important to treat in unison. And then, of course, we know that diabetes and kidney disease especially, and hypertension, have no symptoms. And so rarely do I feel bad from my symptoms early on, but I certainly could feel bad from my treatments. And so as we're looking at navigating this in the primary care space, we have to talk about why it's so important to take a treatment that might have side effects, even though they have no awareness or symptoms at this time. So I wanted to really anchor this point quite a bit more. And this is a detailed case, but I feel like it's an important example of what you might see in primary care, because the majority of the people here today are not primary care. So this is a real patient. I've shared this before. Bobby is a 54-year-old female. She's had type 2 diabetes for about 12 years. She had control for a while and really felt things were going pretty well until she reached menopause. But since then, it's been much harder. She is on multiple therapies. She takes metformin, 1,000 milligrams twice a day. She takes glipizide, 10 milligrams twice a day, and insulin glargine each evening, 64 units. She used to check her glucose, but she really has stopped checking it because it just frustrates her. The sugars are high. She doesn't know what to do when it's high, and really is not sure why she's doing this if she can't do anything about it, because it's just beating her down and making her feel bad. Now, saying that, she also has spells at least twice a week where she wakes up early in the morning, or if she misses a meal, where she feels shaky. These spells, if they occur, she'll eat something and will feel better. But if she has them, she's going to skip her insulin that day. And then finally, as for her complaint when she came in, she hurt her neck last night and she's not sure what happened. She'd like to get this checked. We do have some additional history. She eats meals twice a day. She does home care, has a very unpredictable schedule. It's based upon how many clients she's seeing that day and what other problems she has. And again, I know that there's a lot of granular detail, but if we're going to kind of get at this, this is the kind of detail I need to manage her disease. She's got a past medical history of type 2 diabetes, dyslipidemia, hypertension, fatty liver. She's had coronary artery disease as well. And so, I have the luxury here even seeing the timeline for those. You can see her medication list. She's on simvastatin, she's on an ACE, she's on a diuretic, a beta blocker, metformin, and then about her diabetes med. No allergies, and again, she's got some non-specific complaints of fatigue, poor sleep, knee pain, and some swelling. She's obese, she's got an elevated blood pressure, she's got truncal obesity, and she's got edema. So I hope for those that see patients that this would be not an uncommon presentation, not an uncommon scenario. To pull in some labs, she's at an A1C of 8.8%. You can see her creatinine is elevated to 1.4 with an eGFR of 54 ml per minute. Potassium's okay. She does have proteinuria with a albumin to creatinine ratio of 368. And she's got very classic diabetic dyslipidemia that we see in type 2 diabetes with high triglycerides and low HDL. She's got elevated transaminases, and for the sake of today's argument, we'll say that we know that that's from fatty liver. And so she's got a lot going on. And so as a primary care physician, this is the kind of things I need to sort out. You know, what's on my problem list for Bobby? What am I going to do first? Do I have an A1C goal for her if we're thinking about her diabetes treatment? What are my steps for blood pressure, glucose, and lipid control? What are the unique features that I now have to think about because she's got atherosclerotic cardiovascular disease? What are the unique features I need to think about because of her fatty liver disease? And are there any special treatments I need to address her diabetic kidney disease? And then going back to that team-based model, who should be on her diabetes team? And does that need to be different, or is it similar to the cardiovascular team and the kidney team? So I hope that this very quickly becomes overwhelming. Because again, Bobby wants to talk about her neck. She doesn't necessarily want to talk about all these other things, but these are the things that I'm thinking about and trying to balance the competing agendas of how do we manage chronic disease in a primary care setting that's more focused on episodic care. So here's a short list. Maybe you already made your own list. In my mind, she's got uncontrolled type 2 diabetes. She's got hypertension. She's got mixed dyslipidemia. I think she's got hypoglycemia, which is going to be one of my priorities. We know that she's got atherosclerotic cardiovascular disease. She's got obesity. She's got stage 3A, A3 CKD, maybe diabetes burnout. Maybe she's tired of doing all this, and probable non-alcoholic fatty liver disease. Well, that's my list. Her list, she's worried about her neck pain. She's worried about these spells, and she might be worried about her edema or fatigue. And so it's important, if we're going to be working on this together, that we're able to balance both of these agendas so that we can come with a mutually agreed upon plan. And so this is quite hard. So we want to take this case and kind of frame it into some of the challenges that we see in primary care. So certainly, what is the knowledge base as it relates to diabetic kidney disease? And actually, the understanding of primary care knowledge, at least from my search, has been relatively limited. I think that there's good evidence across primary care that we need to be screening for diabetic kidney disease through both creatinine and albuminuria. But despite that good knowledge, only about 50% of patients have had an albuminuria screening. And that varies depending upon the study, but certainly we could be optimized. Even the first step of that process is making sure we know whether someone has albuminuria or microalbuminuria. I think there's very substantial knowledge of using whether we should be using an ACE or an ARB in patients with hypertension or nephropathy. But I think often we don't maximize that dose to really be at the therapeutic dose. I saw a patient this morning on 2.5 milligrams of lisinopril for her initial consult. And I asked what she was taking that for. It was to protect her kidney. Well, again, do we have data that is nephroprotective? And then I think one of our biggest challenges is what's the optimal time for referral? And I can share my personal experience that where I'm at now, I have really good support. I have a team that I can reach out to. I had a text from my nephrologist this morning asking me about a shared patient. So I feel like I'm connected to a team where referrals are very dynamic and I get good feedback. I've been in other practices where I didn't have readable access to a nephrology team. And I didn't know when, because I have so many patients that need to be seen. When's the best time? And I've had plenty of consults where I've sent in and the consult came back, well, do nothing different right now, the patient's fine. And that can be maybe frustrating for the patient and the provider. Did I send them too soon, too early? Conversely, I've also sent patients and, I feel like I've maybe handicapped my nephrologist if I send them too late and then we can't change that progression of diabetic kidney disease. What I found in that rural area is we actually asked our healthcare system to bring a nephrologist into our practice every other week. So one day, every other Friday, we had a nephrologist come, and our patients were able to see nephrologists in a center where they were familiar with, and we were able to have those discussions with the nephrologist right then and there. So to me, that was a really good option under that care setting. In this care setting, I have a nice support. I think there's certainly good knowledge in primary care regarding nephropathy as a complication. And I think there's good knowledge that both hyperglycemia and hypertension contribute to nephropathy. But I really feel like in primary care, we could have a better understanding of renal replacement options, because I feel like so much of this, especially with advancing kidney disease, is helping our patients to prepare to know what to expect. Because I don't know about you, but anyone else, I don't know about anyone else, but for me, if I don't know, I'm going to default to the worst case scenario. And I think that, again, information can be really useful to know what someone's chances are, what their risks are, and what the plan would be if things got worse. And so that's an area I think primary care we could be doing better. And then this is an area that I think the dating is emerging and is certainly very important, but it's not widely known in primary care. I don't think that DKD is a major predictor of not just end-stage renal disease, but cardiovascular disease. And in fact, way more people are going to die from cardiovascular disease than they are going to progress to end-stage renal disease or dialysis. And so we really need to start pulling these things in together, that this is not just a kidney problem, this is a cardiovascular problem. And again, these teams that I purposely made them separate initially, maybe they don't need to be separate. Maybe we really need a diabetes care team that includes all of these people. And then this is from Dr. Tuttle, and really we're seeing the relationship between the kidney and the heart as intimately related and a bidirectional pathway. And so it is very important that as we look at the management of cardiovascular disease, we're also looking at the management of renal disease and vice versa. And this is certainly, I talk a lot in the primary care space that small changes in creatinine are very important early on, and that we don't want to, if creatinine goes from 1 to 2, you essentially dropped a kidney, you've lost 50% of your renal function. Those small changes make a difference. What I like from this here is really shows you that going from no nephropathy to microalbuminuria, you essentially are doubling your risk of death. And while it's a small percentage, doubling is still really important. So we need to pay attention earlier in the disease process so that we're identifying people earlier in the spectrum, 1, to reduce their risk at the time, but 2, to slow the progression overall. And again, I am amazed, and I've used this in many of my lectures, that the heat map is known, but rarely understood. And so I think that this is an area where we really could highlight. And for me, I actually like to put this in my patient room and actually show them where they are on the graph. And not as a bad news tool, but it's to say, this is why it's important for us to move things either to the left or up. And if I could be king for a day, if I were going to remake this heat map, I probably would get rid of A1 and move it over into the EGFR space, because I think that one of the things that people forget is that they're not tracking the protein excretion correctly. So, and I have done that myself, thinking that, there's 2 steps, right? A1 would be albuminuria, and step 2 would be macroalbuminuria or proteinuria. That's not at all the case. You're looking at people with normal protein excretion and still seeing the effects from GFR alone. But that it can be a confusing point for those that don't spend a lot of time with the heat map. And then this is just the last piece, and I actually wanted this slide to be a bit lower, but this was my mistake. Despite the incredible expansion of tools that we have to manage diabetes, we still really have not made a lot of progress in terms of those that are at A1C control and those that are not at a very high elevated A1C. So despite having more tools, we have the same burden, at least from a glucose standpoint. And then this is out of New England Journal. This is basically showing you that in terms of processes of care and outcomes of care, we could do better. A given patient has only about 50% have an A1C below 7%. About 50% have their blood pressure goal, and only about 2/3 are an ACE or an ARB if there's albuminuria present. And that's if the albumin was checked. And then this is always scary, but this is actually good news. What percentage of patients have all 3 and a goal at once? It's about 14%. And being in this space, I know how challenging this is, because again, we have patients with multiple medical problems, and most of these things are silent. So I want to shift now just briefly to the patient perspective. And again, I take this from working with my patients. I find that many of my patients really don't have a good understanding at all about diabetic kidney disease, or I had a patient actually about 3 months ago come in, young guy, newly diagnosed with type 2, and he said, well, I guess that means I'm going on dialysis. And of course, neither one of those are actionable, right? I want someone to be informed, but I also want to know that we have a lot of control about your progression to end-stage renal disease, and we can prevent it in most people. But if all you've seen is in your family, people get diabetes and then you have kidney disease, it's reasonable to think that that's the normal pathway. So we really have to change that narrative. And I think that narrative is both through primary care, letting people know that there are other pathways, but two, we have patient panels today. I love that we have patient representatives, because these success stories and real life stories from someone with diabetes are the most powerful messages for other people with diabetes to know there can be other pathways. And then we need to really educate our patients that there is good opportunity to change this progression. Even if we can't stop it in everyone, we certainly can change the time course. And, certainly most people I know would be happy to be well longer. This is NHIN's data just showing you how significant of a problem is that people with CKD are unaware of their kidney disease. So you can see here that this is stage 4 in the green. You've got stages 1 through 3 below, but really less than 10% of patients with stage 1 through 3 have knowledge of CKD. And then you could stage 4, it goes up, but that's an average of still 25%. So this is still a concern, because it's our job to let people know what they're dealing with. And even with patients with albuminuria and low GFR, you can see that if you have one or the other, you still have problems with very low awareness at the patient level that they've got nephropathy, either from filtration or through albuminuria. And it does go up, but it goes up to 25 to 30% if you have both. So this is an opportunity for us in primary care to raise awareness of someone's condition. And then these are data that I think, I don't know how I'm going to do it, but I think it's important for us to share with our patients that if you look here on the left, and I put the arrows in, if I could help my patient prevent going from stage 3 to stage 4 CKD, look at the change in death. The rates of death go up dramatically when you go from stage 3 to stage 4. And this would be an important reason why we need to work together to prevent that. Again, same thing with hospitalization. And again, I'm showing you patients with both cardiovascular disease and diabetes relevant to the patient I showed you today for Bobby. So if I could help Bobby not go from stage 3 to stage 4, that's going to make a meaningful difference both in death and hospitalization. And then this is also, and again, I circled the age range that Bobby's at. She's 54 years old. If I could help reduce her current problems of both proteinuria and lower eGFR, you can see that that if she's got both, you can expect a 10-year shorter life expectancy. And again, this is a meaningful difference for our patients. These are important things that we really need to address and let them know that these changes make a difference. Even if they don't feel them, they make a difference in both hospitalizations, morbidity, and mortality. Okay, so that's all the bad news. Let's talk a little bit about potential good news. So how do we start the conversation with our patients? Well, I think knowledge is power. Very rarely do my patients not want information. Information gives them at least the ability to make choices. And I think one of the things that we spend a lot of time about, it's not just about numbers, but I want you to know your numbers. If you know your numbers, you can know if things are changing over time. I think it's important for us to let our patients know that most complications are preventable. And the earlier we get at it, the better. And so, my initial appointments with patients with diabetes and CKD or DKD, we have a lot to talk about. And I say, I know that this is a lot of information to take in, but time is not our friend. And we want to get ahead of this so that we can reduce the risk downstream. And one way that I do this is I use a checklist. And so I'm going to show you one of the handouts I give my patients. It's divided into multiple pieces, but it is useful for a conversation tool. So in my handout, we talk about, this is the glucose-centric piece. When do I want them to check their glucose? What should their insulin doses be if they're on things other than insulin? Oh, sorry about that. We talk about their blood pressure. What's their blood pressure goal? And when should we be using aspirin and statin therapy? And again, we don't always do all of these things right away, but I want patients to know these are all things we're going to be thinking about as we're moving forward. And then on the back, and I use this for my patients who want to kind of know, these are the things that we should be thinking about and doing. And while this can be overwhelming, what it does allow us to do is let them know these are the things that we're going to eventually get to. We may not get to all of them today, but we definitely want to do them regularly. And so I actually will ask my patient, did we get this done today? Yes, they mark it and they get the date. This is not only good for me, but it's good for all the other healthcare providers that they see. How often should they get their A1C checked? How often should it be checked for kidney function? And what should that check be? And then what should their blood pressure readings be? And then finally, should they be on these other ancillary therapies, including aspirin, statin, and so on? So again, this is not specific at all to diabetic kidney disease, but what it does is it gives a framework of all these problems that Bobby or any other patient's handling, and it gives us something that we can work with. And maybe we need to put some things in here related to diabetic kidney disease, and maybe that's what we'll work on today. This is a graphic from NIH, and I think it's actually a lovely graphic because too often people, we say numbers, but these numbers may not have context. So what I like about this is how well are your kidneys working, right? So it's very simplistic, but it also is meaningful. Are you in the normal range? Are you in the warning range in the yellow? Or are you in the kidney failure range? And again, it gives you these ranges that, that you can mark and say, this is where you're at. And again, this is just half of the equation. The other half being, of course, looking at protein excretion. And I like to share with my patients that there's a lot we can do to reduce diabetic kidney disease, right? We're going to control glucose. We're going to control blood pressure. We're going to also work on causing weight loss, reducing weight, also quitting smoking, and making sure our patients are informed of their status. Again, if you know where you're at, it's way easier to prioritize what you want to prevent or where you're going to be. And then what are some office-based solutions? And these are, I think, let's talk about them in our breakout groups. I think keeping the problem lists up to date. I also like to put dates on them. I make lab testing as part of my pre-visit planning. So my MAs will go a week ahead of time and make sure that everyone that is due for labs has labs done. It's my opinion that primary care should see our patients at least 4 times a year just for their diabetes and diabetes-related conditions. Too often, patients come in and they have other complaints, and then we're not sure, are we going to do this other complaint or we're going to do diabetes? This is such a significant problem that this deserves 1 hour out of the year. That's all we're asking is 1 hour out of the year to focus on diabetes and diabetes-related conditions. And then I actually have had some success rotating our themes. This is just one example that it actually changes a little bit over time, but maybe my winter visit with them is focused on mental health and preventions, immunizations and eye exams and other appointments. Maybe spring is focused on cardiorenal before people start to get up and moving again. Summer is looking at hypoglycemia and other microvascular complications. And then fall is preparing for the holidays to make sure, one, you've got a plan so that you don't kind of lose track or lose ground during the winter months, as so many people do with diabetes. And then this is another thing that I've done, and I think it's consistent in the lipid world. We need to stop ordering fasting labs for our patients. So often my patients don't get their labs done because they're afraid to go hypoglycemic when they're fasting. And the majority of the labs that we do really don't have to be fasting. And so I think that as much as it is relevant, that might make it easier for us to get the lab test for our patient. And Dr. Tuttle's going to talk a little bit about kind of the KDIGO guidelines and as it relates to treating diabetes kidney disease. But what I like to show here is that we have so many options now. We have medications that are particularly good for diabetic kidney disease. We have ones that are good for the heart. There's ones for weight loss. So we have so many choices. And I think it's important for us, if nothing else, to have some kind of reference tool. And whether that's the ADA algorithm or this, it's good to have kind of a map. Any map will make a difference. And I actually find that putting this map in the patient rooms is actually nice because it lets the patient think about, hey, well, so I'm worried about this thing that has high risk of low blood sugar, or I don't want to take an injection. It allows us to have a more collaborative discussion when I know that we have information for my patients to work from. So what I left you with, I hope today, that certainly diabetic kidney disease is common. I think that many healthcare providers and certainly many patients do not know their status, which I think really is the first and most important step to moving us forward. There's certainly a lot that we can do, including making changes in our office-based setting. There are opportunities and processes of care, but most importantly, we need to raise awareness. We need to unmask the progression of diabetic kidney disease so we can reduce fatalism, and then certainly look at a kind of targeted approach based on our patient, but that starts with a plan. So I look forward to talking to you all in the breakout groups. And we're going to hear from Dr. Tuttle regarding what are some of the best practices in managing diabetes and diabetic kidney disease.
And I want to be sure to acknowledge Dr. Josh Newmiller, who had been scheduled to give this talk and had an urgent issue. And I'm stepping in on his behalf and happy to do it, but know that you will have missed a great presentation by Dr. Newmiller, and I will do my best to use his slides and cover this very important topic that really builds on this talk from Dr. Shubrook, where we really were grounded in the realities of daily practice, and to talk about how we can then move forward to implementing best practices at the point of care, because really Dr. Shubrook's clinic and clinics like it around the clinic and around the world are where the action really happens. So the outline will be to first discuss the kidney outcomes with SGLT2 inhibitors, but also for GLP-1 receptor agonists, another emerging class of glucose-lowering therapies that also have heart and perhaps kidney protective effects. I'll discuss the current guidelines for use of glucose-lowering agents in patients with diabetic kidney disease, and then some considerations for how to use these agents at the point of care, particularly with a focus on how we manage background therapies and risk mitigation strategies. And then finally wrap up with a discussion of barriers to implementation of and optimal use of recommended therapies with some suggestions of how we may move those barriers aside and get patients the treatment that we feel is best. So first, with regard to the kidney outcome trials, the cardiovascular outcome trials outlined here, EMPA-REG, CANVAS, and DECLARE-TIMI 58 are really the gift that keeps on giving, because these trials were initially mandated by regulatory agencies in the US, that would be the FDA, to establish the cardiovascular safety because of a history of prior glucose-lowering agents that post-approval were associated with cardiovascular risks. And the good news is that the people who designed these trials were somewhat prescient in that they made a statistical plan that if they met the quote non-inferiority margin, which meant no increase in risk, that they could go on to test for benefit. And in fact, there were clear benefits, particularly on reduction of risk of heart failure, but also on the so-called three-point MACE, atherosclerotic events of myocardial infarction, stroke, and cardiovascular death. But importantly, a secondary outcome across all these trials was, quote, worsening nephropathy. And at the time these trials originally were published, this was somewhat of a surprise, but note that the risk reductions are really substantial in the range of 40% or more. But also remember, these are secondary outcomes. However, this teed up the two large kidney disease outcome trials that have subsequently reported out, canagliflozin with Credence and dapagliflozin and DAPA-CKD. Both of these trials were stopped early for overwhelming efficacy. And for the nephrologists, as well as the diabetologists and primary care specialists here, I'd like to point out that we had never had clinical trials stopped for overwhelming efficacy in the history of the field. We've had trials stopped for safety or futility, but the first trials ever stopped for overwhelming efficacy on the primary outcome. Oops. Let's see if I can go back. Note the hazards ratios here for the primary outcome. These are kidney disease events, heart events, kidney failure, dialysis, transplantation, GFR less than 15, or death from kidney disease. Hazards ratio 0.7 in credence and 0.61 in DAPA-CKD, which also included cardiovascular causes of death. And about a third of these patients had non-diabetic CKD. Also, DAPA-CKD was the first trial ever in our field that has shown a reduction in risk of all-cause mortality, a 30% reduction. That's a very high bar to meet for any therapy for any disease condition. That's right up there with beta blockers post-MI. So as Dr. Model said in her introductory comments, this is a pivotal time. We now have therapies that save lives, and among the living, reduce major cardiovascular events, which are the most common causes of death. And then among those people, we also have a 40% reduction in kidney failure. So there really is, if you will, even a moral imperative to get these drugs and these approaches to care to the clinic as quickly as possible. The GLP-1 receptor agonists have followed a parallel story. They were studied in a series of cardiovascular outcome trials originally for safety. They too delivered with regard to reduction in risks of nephropathy. In these secondary outcomes, they're in the range of 15 to 35%. These medications also have a significant effect to reduce 3-point MACE, so cardiac and kidney protective. This is from the meta-analysis that included the cardiovascular outcome trials showing the secondary kidney disease outcomes, significant risk reduction with a hazards ratio here of 0.83. But without the albuminuria endpoint, it just misses statistical significance. But remember, in a group of people who are selected for cardiovascular risk, they have either normal kidney function or very early CKD. So we're much more likely to see an effect on the earlier indicator of kidney disease, albuminuria, than on GFR decline, which usually occurs later. This trial was the first trial with a GLP-1 receptor agonist conducted in patients with low GFR, CKD 3 to 4. You see here the mean baseline GFR was 35. This was a study done where the primary outcome was a glycemic outcome. So it was an active comparator between insulin glargine and 2 doses of dulaglutide. But the main secondary outcome was GFR. And as you can see, the insulin-treated group had progressive GFR decline over 1 year, but this was essentially abrogated by either dose of dulaglutide. This is now led to a major kidney disease trial called FLOW, using the GLP-1 receptor agonist semaglutide, now being tested in a classic kidney disease outcomes trial, very similar to what was done in CREDENCE or the diabetic component of DAPA-CKD. This is about to complete enrollment. It won't report out for probably a couple more years, but this is an active area of development. And then importantly, we've already moved on to combination therapies. So the study EMPA-SEMA is actually looking at semaglutide and empagliflozin together. In this case, it's a phase 2 trial looking at the primary outcome of albuminuria, which is what we use as a readout for an indicator of likely to be beneficial. And then, of course, secondary outcome measures are GFR and various inflammatory and endothelial biomarkers that we think may be modified by the treatment. So while this therapeutic area is not quite as far along as the SGLT2 inhibitors, it's rapidly emerging. And there are already some benefits for kidney patients that I will discuss in a few moments. So that leads us to the current guidance for use. And for this, we will be looking at both guidelines from the American Diabetes Association, also known as the ADA Standards of Medical Care that are issued every year, as well as KDIGO guidelines. And just to show you how quickly this field has changed, don't try to read any of this detail here, but even as recently as 2017, the ADA guidelines for use of glucose-lowering agents was entirely focused on glycemic outcomes progressing through monotherapy, usually starting with metformin, and then dual therapy, adding other agents to metformin, and then triple therapies, what you add on next. Look at the standard of care for glycemia lowering agents in 2021. In just 4 years, this has just completely exploded. Certainly there is on the right panel the emphasis on glycemic management, which without a doubt is the cornerstone of good diabetes care. But note on the left, we now focus on the use of these agents for organ protection, independent of whether or not they're needed for glycemic control. The ADA still recommends that these agents be used in combination with metformin because that's the way most of the studies were conducted. But as you'll see, not all organizations are even recommending metformin as first-line therapy when target organ protection is the primary goal. If either heart failure or CKD, SGLT2 inhibitors are now preferred therapies. But for people who can't take an SGLT2, a GLP-1 based on the cardiovascular benefits and the emerging data suggestive of kidney benefits. And in people who have primarily an atherosclerotic risk profile, GLP-1s and SGLT2s are really on equal ground in terms of cardiac protection. So the key concepts are that for atherosclerotic CKD in a patient with type 2 diabetes, that either a GLP-1 receptor agonist or an SGLT2 inhibitor be used. If there's predominant heart failure symptomatology or phenotype, then SGLT2 is preferred. If CKD predominates, they emphasize the importance of SGLT2 or a GLP-1 receptor agonist if the patient can't take an SGLT2 inhibitor for some reason. And for those who have low GFR, again, the same considerations, but really emphasizing the use of these glucose-lowering agents for organ protection independent of glycemia. Now we turn to KDIGO, which is the international guideline forming group in the nephrology field. And note that they basically are singing the same song, at least in the new guidelines that were published last fall for type 2 diabetes and CKD. The recommendation is that SGLT2 inhibitor be used with metformin. And again, that a GLP-1 receptor agonist is next in line, either if needed for greater glucose lowering, because SGLT2s are not very potent glucose lowering agents. And oftentimes people do need something else, or in someone who can't take an SGLT2 inhibitor. For example, if the GFR is below 30, they're recommended not to be initiated. But we can use GLP-1 receptor agonists in patients with GFR as low as 15. I would like to point out that if an SGLT2 inhibitor is initiated and the GFR drops below 30, that they should be continued until kidney failure or initiation of dialysis or kidney transplant. And then other agents fall in line if needed for better glycemic control after GLP-1s. Dr. Jay Shubrick showed you this matrix, which is really a guide to, if you will, personalized therapy. And I won't repeat that again. In this publication, we summarize the different evidence-based guidelines. I've talked about the ADA and KDIGO, but also our cardiology colleagues in Europe and the United States have issued guidelines on this exact topic, including CKD, along with their traditional domains of atherosclerotic CVD and heart failure. They are largely the same, but I would point out that the cardiology groups are really ahead of the diabetes and the nephrology groups to now recommend that SGLT2 inhibitors be given even without metformin for their cardiovascular benefits. The American Heart Association has stayed silent, awaiting data. I am on this committee as well, and will tell you that that was an intentional no comment because of the rapidly emerging data. But I think that you may begin to see an evolution to where these agents really are first line for organ protection, irrespective of metformin. Let's talk about going back to the point of care, where Jay brought us into this discussion. And talk about some of the practice points. So in KDIGO, practice points are issued where there may not be enough evidence but to make a guideline, but where there is, if you will, experience and wisdom that helps clinicians guide implementation of guideline-based recommendations. So again, for those who need additional glucose lowering, there may be an increased risk of hypoglycemia that needs to be managed. I'll talk a little bit more about that in a moment. And the choice of an SGLT2 inhibitor should prioritize the agents that have been documented in clinical trials for kidney or cardiovascular benefits. The importance of safety and withholding SGLT2s during times of prolonged fasting or procedures or critical illness because of the risk of ketoacidosis. And the importance of acknowledging volume depletion and diuretic management, and again, sick day management to avoid episodes of volume depletion, hypotension, or a reduction in kidney function that may be volume related. And also emphasizing that based on the mechanism of action of SGLT2s, where we believe that they further reduce hyperfiltration, you may see a reversible decrease in eGFR, but it is not an indication to discontinue therapy unless it is a large decrease and it's believed to be due to something else in most cases. And again, emphasizing the importance that even if the GFR drops below 30, that the SGLT2 inhibitor can be continued until the patient receives some form of kidney replacement treatment. This is from Dr. Neumiller, and he gives us the doses. I won't read these to you out loud, but at the present time, only canagliflozin has the label for diabetic kidney disease. Dapagliflozin is in a breakthrough therapy status for FDA consideration, but has not yet received a label. IMPA is under study in the IMPA kidney trial, and also there's still in the label some restrictions based on GFR. So just to make you aware of those, that it takes a little while for the regulatory agencies and the label to change even after the clinical evidence is generated. With regard to mitigating hypoglycemia risk, in patients who have an elevated A1C, there's usually not a need to adjust agents. But the main agents we're concerned about with regard to hypoglycemia would be the sulfonylureas, which promote pancreatic insulin release or insulin itself. In these cases, when the A1C is less than 8.5, you may reduce the sulfonylurea dose by 50%. With regard to reducing the insulin dose, this is somewhat controversial in the sense that insulin is our best defense against ketoacidosis. So do that judiciously, but remember also that the SGLT2 inhibitor organ protective effects appear to be largely dose independent. So there's also the possibility of reducing the SGLT2 inhibitor dose and maintaining the insulin, particularly in someone who is thin and has been a long-time insulin user, where their risk of ketoacidosis may be higher than in other individuals. With regard to hypovolemia, again, some have recommended reducing diuretic doses. This really should be based on individual patient assessment. As nephrologists, of course, and seeing patients with more advanced CKD, we're often fighting the opposite problem of volume excess. And in this case, the SGLT2 inhibitor can be a welcome addition for volume control. But among people who may not be in that state, be cautious and reevaluate within several weeks to determine whether or not the patient needs a diuretic dose adjustment. Also, if the blood pressure is elevated, these agents also have a blood pressure lowering effect that may be beneficial. If a patient is close to goal blood pressure, older, frail, you may consider reducing an antihypertensive dose. But again, more commonly than not, we're going to reevaluate that patient within several weeks, a month after starting an SGLT2 inhibitor, in which case blood pressure control and volume status can be reevaluated and medications adjusted at that time. This is from a very nice piece in CJSON by Sophie Zungus and Ian DeBoer on a practical approach. Again, I won't read this out loud to you. It basically, in a graphical format, recapitulates what I just discussed. But again, the importance of patient education, again, management and self-empowerment, sick day protocols. People should know to stop these medicines if they are ill, even with a viral upper respiratory infection or gastroenteritis, and the importance of good inspection of the feet and foot care, and then the indication to stop these medicines around the time of procedures. Again, patient education is really critical. And then, as Jay discussed, the team approach to also have a group of individuals who together are managing and advising people and giving the same advice so that we're a united front and that it's clear to patients how to use these medicines safely. Again, this just recapitulates some details with regard to sick day protocols of temporarily holding the SGLT2 inhibitor. And in patients, again, who we consider at high risk for ketoacidosis, it may even be worth asking them to measure ketones. The simple way to do this is urine ketone sticks, but there are also ketone meters, but that may be a little too complicated for most patients. And then again, the importance of educating about holding the SGLT2 inhibitors around procedures, hospitalizations, and acute illnesses. There has been a theoretical issue raised about risk of AKI, and I think we can safely dismiss that concern. This has been shown over and over again in analyses from the various clinical trials with these agents. This is from Brendan Nguyen's meta-analysis of credence along with the CVOTs, actually showing the opposite. There's actually a 25% relative risk reduction in AKI events. So if anything, these drugs protect against AKI. With regard to the GLP-1 receptor agonists, again, emphasizing those agents that were studied in the CV outcome trials that showed cardiovascular benefits. The main issue here is gastrointestinal side effects, which can usually be easily managed with starting at a low dose and gradual titration. Usually as a practical matter, I'll start at a low dose, reevaluate in a month, and gradually increase the dose because people adjust to it and do quite well over time. These agents are not meant to be used with a DPP-4 inhibitor because in a sense it's operating through a similar mechanism, so there's not likely to be benefit. Then the risk of hypoglycemia is very low with the GLP-1 receptor agonist alone, but like for the SGLT2s, if they're used with insulin secretagogues such as sulfonylureas or insulin, then these doses may need to be decreased. And the other thing I would say about GLP-1 receptor agonists is they are very potent glucose-lowering agents, even in people with low GFR, which is in contrast to the SGLT2 inhibitors. So here's where hypoglycemia can become a bigger issue when combined with sulfonylureas or insulin. And in fact, the GLP-1 receptor agonist can even be used in place of insulin as basal therapy because these agents are also not associated with ketoacidosis. This is just showing the list of available agents and pointing out that dulaglutide in particular can be used down to a GFR of 15. The other agents can be used, but just pointing out again in the label, there's very limited data because the other agents have not been adequately studied in patients with low GFR. So this is just a summary of risk mitigation strategies. A couple that I haven't mentioned, I'll just focus on here. Genital mycotic infections are actually the most common side effect with SGLT2 inhibitors, occurring in about 5% of both men and women. However, there's actually been a very nice study that shows daily hygiene, which is basically bathing and clean clothes, can reduce the risk of these infections by 50%. So really a very simple strategy, requires a little bit of patient counseling, but can help us keep some patients on these really life-saving therapies. We've talked about volume depletion and ketoacidosis. With regard to amputation, this was only reported in the CANVAS program of canagliflozin in the cardiovascular outcome trials, not seen in any of the other CVOTs, heart failure trials, or CKD trials. That said, when the CANVAS report came out, For example, in Credence, a foot care program was implemented, but it was very simple. It was encouraging self-exams and having people take their shoes and socks off at the study visits. Again, a very simple way. And just good diabetes care, good patient care, to look at the feet and make that part of the physical exam. And then we've talked about hypoglycemia, and we've already covered the GI side effects and hypoglycemia with GLP-1 receptor agonists. So I'll wrap up to talk about then, okay, if these things are so great, what do we need to do to get this done at the point of care? Again, Dr. Shubrook really emphasized the importance of CKD identification and awareness. This is something that really needs to happen in the public and across our healthcare systems, and really based on the enormous fatality risks, as well as the risks of kidney failure and heart disease, needs to become a top priority in healthcare. There has been historical avoidance of SGLT2 inhibitors because of the initial label for glucose lowering. This, we hope, will be changing soon with some of the labels based on the trials, but at least with one agent, already the label has shifted to the ability to initiate these therapies with a GFR as low as 30. There has been confusion over clinical practice guidelines and recommendations, but as I showed you in that chart from the cardiology groups, the diabetes groups, and the nephrology groups, we're now really seeing harmonization. We may all have our own format and style, but thank goodness the message now is largely the same. And then again, care coordination, Dr. Shubrook covered this, but there still is some confusion on who does what when. What are our roles and responsibilities? And then the importance of adequate patient follow-up and education regarding risk mitigation strategies, as well as empowering people to self-management. And I guess I would expand this to not only classic diabetes self-management, but let's say organ protective drugs self-management. For example, the knowledge to stop an SGLT2 inhibitor during a period of acute illness. So in this paper that Josh was the first author on, we put together at least our vision of a conceptual model of what would really improve DKD management overall. So harmonization of guidelines, so whatever professional group you look to for guidance, the message is going to be the same. The importance of patient self-management and engagement, using multidisciplinary teams. Again, Jay talked about who's on your diabetes team, and we should say who's on your cardio-renal diabetes team, perhaps. The importance of risk mitigation so that we can keep people on treatment. I didn't have a chance to cover this, but we know from real-world data that we're underutilizing a lot of established therapies such as ACEs and ARBs, and part of it is because we have historically had a fear of risks, and I think there's been some avoidance, and we need to do risk mitigation so that we can keep people on therapy safely. And then, like we're doing today, interdisciplinary education, and recognizing that this is a team sport, not only across specialties, but across disciplines. We have nurses here, we have pharmacists here, we have physicians here, we have other healthcare professionals, and we all need to come together as a team to pull this off to really improving the care of patients with diabetic kidney disease. So this also comes from the KDIGO guidelines. This is a model of care that Juliana Chan, who was on our committee, championed from Hong Kong, where they really use electronic health records to form a registry. And from this registry to assess risk and to stratify risks, then to develop a plan based on the review of that particular patient and their goals for risk factor control, and then team-based, what they've called relay, reinforce, recall. Let the patients know what's going on. Reinforce the key messages, what needs to be done, what is their role, and then recall, staying in touch with people. Surely office visits, but during COVID, we learned that we could do much of this remotely, and the importance of outreach, of using other methods to keep in touch with patients. Depending on the healthcare system, this may be more or less possible. Obviously, it involves resources, but if we pull it all together into coordinated care, we end up with empowered patients and optimal control. and hopefully better outcomes that, even from a cost standpoint, improve the value proposition so that we really do the right thing for people. The current state of US healthcare is largely over here of uncoordinated care and the kinds of data that you've seen, poorly informed patients, suboptimal control, and with the very unfortunate consequences, most importantly for patients, but also for the cost of healthcare. So I'd wrap up by saying that recent clinical practice guidelines stress the use of both SGLT2 inhibitors and GLP-1 receptor agonists for organ protection. And here we're talking about heart and kidney, that patient education and follow-up are critical to mitigate adverse events. There's need for adjustment of background therapies and very important self-management education. And finally, although there are multiple barriers to uptake and utilization of SGLT2 inhibitors and GLP-1 receptor agonists, we see a path forward, a light, if you will, down the tunnel, not the end of the tunnel, just down the tunnel, because there's certainly more to come in terms of new therapies. But we've got to do things differently than we've done in the past. And we will promote self-management and team-based integrated models as a path forward toward that light. And again, thank you for the opportunity. I wish you could have heard this presentation from Dr. Neumiller, but we'll invite him back and you'll get a chance to meet him another time. So thank you very much.
Well, thanks, Dr. Tuttle, for such a great presentation in just the last minute. But this was a great segue really into the breakout sessions, which it's my honor to help introduce here briefly. Okay, thank you, everyone, and thanks, Dr. Tuttle, again, for a great presentation and lead into the most important part of this webinar, which is our breakout sessions today. I'm Frank, or Chip Brocious. These are my disclosures from the University of Arizona and appointment at University of Michigan. It's my pleasure to introduce the breakout session moderators. You've already met Dr. Shubrick, but the others you haven't met yet. We're honored to have Dr. Joanna Hudson, a professor of pharmacy, translational studies, and the Department of Medicine at the University of Tennessee. We also have Dr. Patrick G., who is really our most important task force member. He is a patient representative, has walked the walk of the patients that you heard about in Dr. Shubrick's talk, and those of you in his breakout group will have a great session, I'm sure, because he knows all sides of this of these issues with diabetic kidney disease. Dr. Alan Kleiger is from Yale University, a leader there, and also leader of multiple task force in the ASN, but is lending us his expertise on the DKD task force as well. Finally, we have Dr. David Cherney, a very well-known clinical investigator who has actually done many of the studies that you see data from in the last two talks, and will also lead our final group. So welcome to all of you. The disclosures are there. I'm not going to go through those. I do want to spend just a moment going through the questions that we're posing to everyone here today. This is where you have to do the work. We really are trying to move into the space that Drs. Shubrick and Tuttle outlined for you. And how to do that is obviously not trivial. So what are the current barriers and challenges, and what are the easier solutions that can be implemented widely to help achieve those? And then how do we really move towards the team-based approach that you heard outlined by our two previous speakers? And those are some of the sub-questions under that overarching question on this slide. And then how can DKD care really be prioritized as it should be? And how do we implement the strategies that Dr. Shubrick mentioned to get them engaged? Also, how can healthcare systems and payers be encouraged to really support these truly life-saving therapies that Dr. Tuttle really emphasized, their life-saving effects. So how do we get this out to people that need them, that would benefit from them? And as part of that, and this actually came from the participants' questions that were sent to us prior to the meeting, and it's a critical one. How do we ensure that this optimal care and the access to these new therapies is really available and actually implemented in those populations that are more vulnerable and underserved? I mean, that's our real challenge here. So we want all of the groups to take up some aspect of these questions. Now, we understand these are huge questions and may not, I'm having problems getting my slide to advance here. Could you go ahead and advance? There we go. So don't feel that you have to answer all of these questions. This is probably too much for the 40 minutes or so that you're going to have to talk about them. Pick the questions you feel are most important. And if you think there are other more important questions that did not make it to this list, just discuss those. You don't have to have consensus, but please do make some specific recommendations that you think we and then our healthcare system as a whole should go forward with to help improve access and implementation of these therapies. And then your leaders, your discussion leaders that I introduced you to will work with our ASN staff right at the end of your breakout sessions to report your conclusions and recommendations so that we'll be able to share those with the entire group at the end of this meeting right after the breakout session. So don't go away. We want you to participate in all of this and as we share what each group comes up with later. Okay, so you're going to get placed into breakout rooms, and those of you who, I'm sure all of you have done this before with Zoom, it's going to take a little bit of time to get all 80 of you into the different 5 breakout rooms. So be patient. You can get up and stretch if you need to, run across the hall if you need to, but please come back and be sure to share your webcam and unmute your line as soon as you get into the breakout room. But do give it a couple minutes or so to get you into the room. And then at the end of the sessions, you will see this prompt where the breakout sessions will be concluding. There will also be a little warning about 5 minutes beforehand to allow you to wrap up and to allow the moderators to put together the final document that you'll be sharing with us. So now I think you can stay tuned to get into your breakout rooms. And we look forward to discussing what you come up with in about 45 minutes. Thank you.
I think we're all back, and it sounds like we didn't have time to do that last piece. So with the notes taken by the note taker, perhaps the moderators can abstract from them as we do our presentations, Chip.
That sounds good. Yes, I didn't see that 5-minute warning either. So yeah. So anyway, thank you all. I'm sure all the other sessions were like ours, where we could have talked for another 2 or 3 hours on each of the questions, and so we'll see how well the moderators can pull together the comments here and do what you can do, please. And I think the ASN representatives will provide you a slide with at least some notes on it that you can use to do your reports. I'm going to call on each of the moderators in turn to give us an idea of what your breakout session talked about and suggestions. And so we'll start in the order that I introduced you so I can stay organized. So Dr. Hudson, unfortunately, I have to pick on you to go first, if you don't mind.
No problem, Dr. Brosius. So we had a good discussion. Obviously, we had the same challenges of most groups of being able to fit a lot into a short period of time. We were represented by physicians, included endocrinologists, nephrologists, family medicine, nursing, as well as industry, and myself as a pharmacist, a former PA as well, or a PA who's now with industry. So a good group. So I may ask if we could see, is there any way I can see our notes section, the slide with the notes underneath it, or no? If not, I can summarize what we had.
Yes, please stay tuned. I'll have them up just a moment.
Okay, that's fine. I can start talking already. So we went through the first question to start off with about barriers to managing DKD in primary care. And I think the first thing that really came up was the barrier of kind of insurance coverage, knowing what is on a formulary at a given site and how that would relate to what could even be implemented for a patient. So that related, I think, a lot to some of the other questions in terms of even access to care for underserved who don't even have insurance and are not even necessarily considered in terms of in terms of any insurance whatsoever. So that payer inertia, I think, came up with regard to that. So other things that came up, I think, is in terms of the time to address all the aspects with the patient. So that includes, and I know that was mentioned in Dr. Schubrook's discussion, but a patient comes in for one particular problem, and how much time do you have to even cover all the other aspects in terms of coaching and counseling if you want to start another therapy for a patient. And that was, I think, a big piece of what was mentioned with regard to some of the barriers there. And the other issue is, I think, with regard to primary care experience with some of these newer agents. When patients come in, if you're even thinking about implementing, SGLT2 inhibitors, as we spent time talking about, we're not only asking folks to understand what these agents do, what the adverse effects potentially may be, but we're also having them do it in fairly complex patients without a whole lot of guidance, right, in terms of the education piece. So I think the need for education came up as well, not only for the providers with complex patients, but also with the patients themselves. Let's see, what else did we have? The other thing that came up was failure to diagnose kidney disease. The right test may not be being ordered. Referrals to other specialists, while important, can sometimes be cumbersome to initiate. And not everyone, we had a primary care physician on the team, not everyone has an integrated system necessarily where they can refer to maybe a nephrologist or endocrinologist as easily as it may seem. And that group may not have access to the health records that are needed with regard to making that an easier process. So those were some of the things that came up there. Trying to think of what else we had. I'm trying to read these notes on here. Let's see. In terms of some other things, so the things that made it on the slide, we also talked about for medicines known to prevent significant morbidity and mortality, there should be a cost abatement for copays, making the easier access for patients for what we consider some of these life-saving therapies. Our patient on the group, Glenda, also brought up that patient support groups would be important. So in terms of how are other patients managing a complex disorder? Are they having the support they need in terms of the patient care, but also are they able to get feedback from other individuals going through the same challenges? So that was, I think, an important thing that resonated with our group from Glenda. The other aspect was with regard to teams, and I know I'm crossing over on several questions, but a lot of our notes ended up on this first slide. But what about the patient-focused team effort? So, for example, should there be a referral service to start patients on SGLT2 inhibitors? But the question that came up is who would essentially be kind of the captain of the team, and how would that be orchestrated to make sure the appropriate follow-up is there, the right labs are ordered for follow-up, et cetera. And if you think about it, for those in the nephrology groups and the primary care groups, if you start an SGLT2 inhibitor, and I'm thinking about the nephrology example, that's more my area. If a nephrologist starts an SGLT2 inhibitor, I think there's a concern of, well, I care about progression of kidney disease, but do I really want to get into the management of ordering an A1C, glucose, all the other monitoring that comes with that typically would fall under endocrine or primary care? So I think that's another challenge, but also relates to what would this team look like to help coordinate some of those things. And then another example, I guess, that came up in terms of how do we help integrate our systems a little bit better would be the electronic health record being able to be viewed by multiple disciplines, prescribers, et cetera, and e-care. And some of you may be familiar with that. There were several in our group who were familiar with it in terms of having links not only for the electronic health record, but also includes education for patients, prescribers, and other healthcare professionals. So kind of as an action point, if there's something that could be developed and more widely used across the spectrum of different disciplines, that would be an ideal scenario. We also touched on, if we talk about the vulnerable population, one of the things that came up is making sure we have information for patients in terms of other languages, increasing the availability of materials that are in other languages, optimizing the LIS benefits to overcome financial issues. And this was a subsidy that is available to some patients that maybe some prescribers aren't aware of. So of course, that's once you get a patient in the system, part of what we're talking about and being able to access care for vulnerable and underserved is even getting them to a primary care physician to begin with. So we didn't even get to touch on some of those things, but obviously that's another barrier and something that we would need an action plan to develop. If anyone else in the group remembers any other burning issues that we had that maybe we didn't capture here, I've tried just to give an idea of the main things we talked about that probably cross over in multiple questions. And I'm sure that from a note taker perspective, we can categorize these under each of the different topic areas a little more coherently, but I think we at least got to get through some of the main issues that we were mentioning.
Great. Thank you so much, Dr. Hudson. And if none of your other breakout group members had anything else to add, we'll move on to Dr. Shubrick and your group.
So I want to thank our group for their active participation. We had nice representation across healthcare, and as well as from patients' standpoint and family standpoint, which I think is so important. We were able to, well, first of all, I'm not shy, if you probably already figured that out. So if I have misrepresented anything, I would welcome the committee to jump in and make sure that you can correct my statement. We were able to answer 3 of the questions, 2 on the list and 1 new one. The first one we really struggled with was, when's the best time to send that referral to nephrology? And, of course, that's a complicated equation and there's not a simple best time. We shared experiences where some come too early, some come too late. I think what I heard from this is maybe some options that would make this better is too late is always bad, but unfortunately, sometimes that's hindsight. But maybe we could leverage telehealth. Maybe we could leverage cross-fertilization of practices and even just consults to direct the next couple of phases for earlier intervention with nephrology, and that might make it better. But we also highlighted that with these new medications out there that have benefits earlier on, and in fact, maybe this does need to be an earlier referral process. And again, I don't know how we're going to come up with another 50,000 nephrologists, but looking forward to seeing us meet that challenge next. But we all recognize that the challenge was when's the best time of referral, and then when we're doing a referral, we talked a little bit about making sure that 1, patients know why we're doing a referral, and 2, there's communication between the primary care team and the specialty team for nephrology to know what the goals are and make that communication bi-directional. I think I hit most of the things there. And I think that we heard very clearly from our team that when there is a team-based approach, you can get really overwhelmed pretty quickly because there's a lot of team members. So to move to the second thing, we asked who should be on the team, and you can see we've got a nice list here. I'm sure it's not completely comprehensive, but we would add a pharmacist, a care coordinator, social worker, endocrine or diabetes team, behavioral health, family members. I think, again, this is so critically important. These visits are complex, and having an extra set of ears hearing things and reinforcing are so important, and community health educator or diabetes educator. And then I think the other thing, and this is back to my original statement, that the primary care needs to endorse the value of each of these specialists if they're going to be involved in care, so we know why it's so important they need to see 5 different healthcare teams. And then conversely, the communication needs to go back and forth so that we're making sure we address the needs of the patient and working together as a team. And then on the benefit side, we did hear that electronic health records have made this easier. We can kind of see things, but still too often people just get dumped with sets of data without a specific request. And so having this kind of going back to the collegiality of sending letters to each other is probably really important, so we understand, one, we're working together, and two, who's responsible for each of the items of care. And then for the third question, we had a peds nephrology member with us. And so what's the data in pediatrics and how are we going to move forward? We have a growing epidemic of pediatric type 2 on top of our patients with type 1. And certainly this is not an inconsequential group that we need to learn more about. And while the data is still pending, whatever we're applying to adult healthcare systems, we should be prepared to address to pediatric healthcare systems. And we already have a disconnect between pediatric and adult care. How are we going to do that across multiple specialties when the training is often segmented and not brought together? And I guess I would highlight, this is a great time to be a primary care doc who does, birth to grave. So I could say I would be that bridge because I know the person, I can treat them along the way. And so pulling that, particularly for kids who get specialty care, making sure that that primary care provider is central in that communication tool may make that transition between adult and pediatric better. I'll invite my panel to add anything that I missed.
Okay.
Surely I did.
Anyone from Dr. Schubert's group? I'm sure there'll be lots more to talk about, but I guess we'll move on to Dr. G and your group.
Yes, it was a very humbling experience for me to moderate this group of professionals. Myself and Derek Forfang were the patient representatives in this particular group, and I certainly encourage the group members to jump in if I misrepresent or misspeak on anything that we discuss. Even though we stayed with question 3, how can DKD care be prioritized? How do we help patients engage in the importance of DKD? There was a lot of intersectionality with the other questions. So one of the first things that we talked about after Derek and I shared our lived experience with diabetes was the language and how things are broken down to the patients. A lot of times they're not simplified. It can be rather complicated, especially when you're diagnosed with a chronic illness and in your mind, you're focusing on the impact of being told that you have an illness versus the information on how to manage it. So we thought that it would be a whole lot easier to kind of break down the language barrier if the language was really simplified. Also, to have patients ask physicians to repeat themselves and further explain when they're giving out information. So this hits to active reflective listening skills when folks are telling you something, and just to be sure that you understand it, you repeat back exactly what's said. I would even also recommend that patients be encouraged to either come in with a notepad or maybe a journal and a pen, and if not, that one could be furnished for them so that they or either their care partner or support system may be there to not only ask questions, but to kind of jot down exactly what's been conveyed to them from their physician. patients being in contact with other patients with similar conditions. Now, when I heard this, man, I almost started doing cartwheels, because this sounds just like a patient mentorship program where you have somebody with the same lived experience that can share their successes and their detriments. But the biggest thing is that they can guide that particular patient in their journey. They can, not only share their story, but they can probably encourage them on how to maneuver certain pitfalls so that they can be successful in the management and even the communication with their physicians. The next thing was to create a template platform for patients to help bridge the gap in misinformation and language that patients can understand. As Dr. Schubert showed, he had a template of what he gave his patients. So the same thing was conveyed. A lot of times physicians want to say, hey, this is homework, or this is how you need to record your activities or journal your activities. This template is great because it puts the onus on the patient to learn how to better manage their care, their affliction. So when they come back to the physician, they can really show the physician, and it will convey that, hey, this individual that I'm treating is actually listening, actually following directions, and we can, not only is the physician encouraging the patient to better manage their care, but it's also encouraging the physician that the patient is trying to take better care of themselves. So that was a great idea. The next thing we talked about was consider consultation on individual patients to better understand patient backgrounds to help reduce the information gap between physicians and patients on diabetic kidney disease, cost, expensive, quality of life, etc. This was very interesting when it was brought up because, people that may live in underrepresented or disenfranchised communities may get one bit of information, but then when you think about the people that's in the more affluent communities, they may get something else. So if we could create a way, a consult so that everybody gets the same thing. It's not only equitable, but it's equal at the same time. Everybody gets the same type of treatment. Nothing special for anybody, but everybody can be able to grasp and to be able to achieve on the same playing field. The next thing is to have a change in approach from the physician and health messaging toward patients. This was also really key in how can we look at how does a physician tell a patient that they may be at risk for diabetic chronic kidney disease. Dr. Chandler brought this up, and one of the interesting things, she talked about the example that she had where the majority of her patients were primarily on Medicare. And it's hard to really bring this up knowing that they may not be able to afford the medications, but there are certainly some other options out there to be able to address this situation. And it also creates an opportunity, so to speak, for dialogue with insurers and payers to be able to address this particular disparity that may hinder folks that really need the medications to be able to find affordable options so that, again, the field of play is equal. System issues. Again, only getting 20 minutes to be with a patient and understanding the primary care limitation. This is a limit on PCPs to be able to talk about diabetes, to talk about A1C, the glucose levels, and all these other things, and then have the opportunity to talk to them about kidney disease. And I believe in this particular discussion, and if I'm wrong, I hope my group will chime in on this, it can kind of break down a particular barrier to ensure that PCPs understand exactly how to explain this, so that when there's a referral to a specialist, that the patient can kind of have some sort of understanding of why they're going to the specialist before they actually get there. The next thing that we talked about was the use of diabetic educators to help patients understand DKD verbiage, diet, and kidney disease. I know for myself, this worked greatly for me. My transplant team, after I got my transplant, did their best to be able to educate me, but they insisted that I go to a diabetic educator, and they worked hand in hand to ensure that I was equipped with the necessary educational resources to be able to manage my diabetic kidney disease. So I thought that that was great. Think of ways to build responses to primary care and patients can utilize and summarize information in a simpler way. Also, standardized basic resources guide that include basic educations, i.e. Google Doc, use of short videos, and those things that are provided. You know, when you think about this, again, it goes back to really simplifying or having workable tools that will help people living with diabetic kidney disease to be able to manage their care. And here again, the group laid out some excellent educational resources, because you also have to think about how human beings receive information. You know, some are good when it comes to hearing it, others are better when it comes to seeing and hearing it. But the majority of people or human beings in this world really understand better when they see, hear, and actually be able to apply the resources. And the last thing that we talked about was to find what patient goals are and their preference on patient education. A lot of this goes toward, you know, what do patients consider their best quality of life? Now, that may differ from physicians, you know, and I'll just use this as an example. In nephrology, we always think that transplantation is the best option for patients, but there are some people that are happy without a transplant and are happy being able to just do dialysis. There are some folks that may want to go and run a marathon. There are other people whose quality of life is to be able to sit on the couch and watch Netflix without any pains or any causes or any other ailment. So that was great to be able to just be patient-centered, patient-focused, and to also listen to the patient preference. So that was our particular list. And at this time, I will open it up for any of the breakout session people from our group to be able to chime in.
Patrick, this is Derek. I thought that one of the comments, just to expand on what you already said, was the cost of the medication for all and providing that it's actually a cost savings. And I don't know if we captured it here, but of keeping people out of the hospital and the cost of one hospital stay versus a year's worth of medication. And I think that's an important message to share with policymakers and insurance companies.
Yeah, Derek, I certainly do agree. You're right. These medical innovations are life-saving. I know for me, I'm on a GLP-1 agonist receptor, and if it wouldn't have been for me getting the education and being a part of this task force, I wouldn't have never known that. And as a patient, I went to my physician and asked to be put on it because I know in my family we have a history of heart disease. So I just like that extra advantage. So you are exactly right. Thank you for that. Is there anybody else from our session that want to chime in?
This is Joanna from the first group. I just wanted to point out something that you said that also Glenda, our patient representative, stated, which is that also making sure the patient knows about these therapies to then maybe ask their physicians about it, kind of empowering them with that information. And then the other thing is trying to get away from language like you are non-adherent and using more positive language of what good things they're doing. Well, you're not taking the medication, but that's because you had this adverse effect. And that was your, reason for not doing that, but not making them, not shaming them, so to speak. That's something that came up that I didn't mention before.
Yes, ma'am. And thank you for mentioning that. That's like a curse word when it comes to patient non-compliance. A lot of times we get blamed, but nobody asks the question as a why. So I'm glad you brought that up.
Hey, Patrick,
Yes.
This is Kevin. Can I make a comment? I'm not in your group, but
Yes.
so, the one benefit that I see the patient mentors is that could also teach physicians too. So there could also be two-way learning there. And the other thing I would just, bring attention, there was an article written in JAMA Open Network showing that within endocrinologists, there was lower utilization of SGLT2 inhibitors. And I guess, maybe, in working with the communities too, is just say, what's the economic impact? These people have been on dialysis. They don't have a future. I mean, they can't work. And even bringing that element up, because I'm afraid that people are going to make the excuse about cost, say, well, people can't get access because of cost, but yet there's no problem getting $100,000 a year for dialysis.
Yeah.
And I guess just trying to make sure that is preempted to people to avoid that. So anyway, just thinking.
Yeah, thank you for bringing it up, Kevin. You are so right, especially when it comes to the the most impactful and underrepresented communities. We really need to do a better job.
Yeah, the unemployment, just emphasizing the high unemployment on dialysis, the high cost, and these medications are pennies in comparison. So
yeah, thank you.
Yeah, I think another thing we talked about a little bit is hope. And I think there's a lack of hope in diagnosis and treatment and the way, we talked about how kind of the message that physicians get, but I think we need more hope, especially with some of the new tools we have. And I don't think that's always expressed. I think it would help with mental health and patients really getting engaged if they felt hopeful.
Yeah, I think, one of the things with me that resonates with me with being a part of this group is to be able to go out into the communities and kind of preach that hope. So I would just encourage everybody that is a part of this particular webinar to do just as Derek has said. We really may even need to consider taking a boots on the ground approach to getting this out there and letting people know that there is hope on the way with the use of these medical innovations. So thank you, Derek, for bringing that up.
Anyone else want to comment on the, or from Patrick's group or not on Patrick's group, but want to comment on these points? Okay, well, why don't we move on to Dr. Kleiger?
Hard to follow that, guys. That was a powerful discussion. Thank you. And maybe I can start in that place because Kevin Fowler was really clear and articulate in our group in talking about the importance of hope and the importance of instilling hope and the importance of having the kind of knowledge that patients need to know what will empower our patients and enable them with the power of hope to be their own advocates and to be able to seek a better life. So, you know, having more empowerment for the patient and more knowledge that allows that clearly is a key piece of these new therapies that are just so exciting, and others, as you know, as a new model of care that really is patient-centered and empowering happens. The headlines, I must say, if I may, we've heard a lot of detail from the other groups. The headlines really of our group were these. First, in terms of current barriers and challenges in our current system, it was the observation that the current system is remarkably fragmented, that primary care doctors most often sit in their offices alone and see patients for limited periods of time, and the opportunity for true collaborative care with a patient-centered team approach. It only happens in very limited places that incent and facilitate that type of a system, and that we ought to be able to help find ways of having that kind of patient-centered, multidisciplinary team that's appropriately incented to, to keep patients healthy and to engage them in the care. And Paul Pileski pointed out that a powerful tool can be the new electronic tools that we now have. Referral needn't be that the patient has to go to 3 different doctors' offices and seek different opinions from different specialists, but rather with the power of communication and indeed maybe what we've learned over Zoom and what we've learned over this last year, that there ought to be more efficient and better ways for the team to have a virtual team that truly does communicate and communicates in real time when the patient perhaps is right in the room, to be able to work as a real integrated team for these new therapies. In terms of the vulnerable and underserved patients, the observation was that those patients so often are mistrustful of the healthcare system and don't seek out the healthcare system, and that if we're going to be effective in getting to diabetics and patients with kidney disease and heart disease in the underserved and vulnerable populations, that we have to find novel ways of bringing the care to them rather than expecting them to come to the healthcare system. And thinking of creative ways such as retail settings, barber shops, other places where we can really set up an opportunity to encounter patients, to maybe survey them, to talk to them, to give information, that would be a powerful way that we haven't used so far. And then in terms of empowering patients to do self-management and instill hope, Kevin pointed out that unlike some other therapies, if we ask patients now what they know about SGLT2 inhibitors or GLP agonists, receptor agonists, often the answer is they've never heard of those things. There is an absence of understanding and knowledge among patients most affected by these diseases, and that we need to find creative and effective ways of sharing the hope and sharing the opportunity with those patients so that they themselves are part of the team and can motivate where we're going. So those were sort of the headlines. We have in these documents some more specifics that are here, but rather than go into any more of the specifics, let me just invite anybody else who was in our group to to talk about anything that those headlines might have missed.
Alan, I would just add one point. I think just kind of going back to, ensuring that physicians are communicating the value of early detection and what those added years can mean to the person, right? Because that gives the person opportunity to have some control in their life and make options, like whether it's home dialysis versus hemo, it's being preemptive transplant, living donation, but the value of that time gained, I look at myself, the 3.5 years I had gained by finding out that I was going to renal failure was a lifetime, right? So it may not seem that way to the physician, but to the patient, that's a lifetime, and a lot can happen between that time. So I don't think that value proposition of early detection and slowing down the progression of kidney disease is fully communicated across all kidney diseases.
Thanks, Kevin.
You're welcome.
Okay, Chip.
Okay. Well, great, thanks. Dr. Cherney, your group will wrap it up. So go ahead and tie it all together.
Great, thanks very much. So we covered many of the same areas that have been discussed. So I'll try to, as much as possible, to cover newer themes as much as I can. We also had a very multidisciplinary discussion, including input from Precious as the patient representative. We had representation from endocrine, nephrology, from family practice, and from industry, which was very helpful for having a very dynamic discussion. We focused mainly on the first question, which is around barriers and challenges, as well as solutions to help with diabetic kidney disease management. And some of the challenges we've discussed were discussed in some of the other groups, and these include the coordination of care between different care providers, which was felt to be often quite fragmented, as some of the other groups have discussed. And we also discussed how the transition from pediatric to adult care, which is especially important in the setting of type 1 diabetes, can be a real challenge around how to arrange referrals, education, and communication between different specialists. We also discussed some of the themes that Alan mentioned around how primary care providers are often overwhelmed with patients with complicated issues around cardiorenal and endocrine disease, and this emphasized the need for patient-centered multidisciplinary care, which is often very hard to achieve unless you're fortunate to have access to resources. For example, as a nephrologist, I have access to a cardiologist in one of my clinics, which is incredibly helpful to make care more seamless and make decision-making more seamless with patients so that they don't have to see multiple healthcare practitioners. Another challenge that we discussed was often the lack of patient awareness around sources of education, and also about how serious kidney disease can be. And we heard very clearly from Precious about that, around how kidney disease isn't often given the place of how serious cardiovascular disease is, and that we probably have to do a better job at emphasizing the need to prevent kidney disease progression, which is something that we can do now with access to some of the newer therapies that we've discussed during this symposium. We also covered the need to have engaged, activated patients to seek out information, and also we've heard from some of the other groups about how to coordinate care and have patient advocates to help other patients become engaged in a way that makes sense and is clear and effective in terms of the mode of communication. We also covered many of the health insurance coverage issues, and perhaps most importantly, this issue around the lack of urgency that physicians, healthcare practitioners, and patients feel around how serious kidney disease is, and that we really have to change that in a very urgent way to make kidney disease an urgent issue that needs to be addressed due to the how serious it is, but also because of the availability of new therapies. In terms of solutions, we heard from Precious around how important it is to make it clear that there are various resources available to patients in, for example, a dialysis unit, dietitians, social workers, nurses, and how helpful they can be to address various health concerns. We've covered many of the communication issues that have been talked about by the other groups, so I won't go through that again. We also talked about the need as a solution to not talk about dialysis as a destination therapy, and this was something that Kathy emphasized, which really resonated, I think, but instead to focus on new therapies and the avoidance of dialysis, given the new therapies that we have access to in many places around the world. And I think I will stop there and see if there are comments that the rest of the group wants to chime in with that I didn't cover, or maybe that the other groups didn't cover in as much detail. Thanks very much.
I just want to add something, and this is related to everything that the other groups have spoke about. We've already acknowledged that patient advocacy groups are very beneficial and help others and help patients to understand how to be involved with their health care, how to be engaged, how to, communicate their concerns. So with that being said, now we have to think of innovative ways where these providers can share these different advocacy groups with their patients and let them know that they are available and that there is support out there for them. So I even challenge you guys to even start your own patient advisory councils. I mean, to just get this ball rolling and where we can all work together and have better health outcomes. I just wanted to add that.
Thanks very much. Yeah, it makes a lot of sense. Any other comments from Dr. Turney's group or anyone else? I'd like to make sure that if you have thoughts that haven't been articulated yet, that we can get them out now. We've got a couple more minutes we could use before Dr. Mardropoulos sums up the whole session. So please, if you have any thoughts. I'll just comment, just to underline what many of you just talked about, but I think nephrologists have a role in that problem of not being urgent enough about preventing CKD progression. I think we've used dialysis as a destination, as Dr. Tuttle was just quoted about saying so appropriately, and that's shouldn't be a destination. And I've had many patients come to me who said, well, I moved into town and I was told by my previous nephrologist everything was just fine, and then they said to get your fistula in and get ready for dialysis, and then and without a lot of emphasis on prevention. And now that we have such important strategies, I think we have to really, as nephrologists and primary care doctors, we've got to start early. And I'm just sort of underlining the comments made by all of you, but we just have to start early and identify folks and help educate and really push this, very, very far forward into the higher GFRs, because, otherwise we're just going to be doing what we've always done. And that's not fair to our patients. Anyway, so that's my last editorial. We now have anyone else, any other comments, final comments?
Chip, I just wanted to say we have to disassociate really deliberately the kind of volume for service reimbursement for this. Otherwise, we'll never get out of this. You can't work any harder than we're already working. So we got to be smarter.
Right. Amen.
But I think, Chip, I just think that there has been an acceptance that dialysis as a destination is acceptable. And I think it behooves the patient community to call that out. If other nephrologists are not calling it out, the patient community is going to say, look, this is nonsense. I mean, if you fully study all the consequences like you all do about the impact of dialysis, I mean, it's barbaric. Let's get real here. But I think it's too, if the nephrologists aren't doing it, the patients have got to call it out and just say enough. And no excuses, zero.
I would also say that with respect to training of our nephrologists, we really need to emphasize diabetic kidney disease more wholeheartedly than we have. I instituted a diabetic kidney disease lecture in our fellowship program because there wasn't one up until 2 years ago. And in terms of training our fellows in terms of using these new medications, encouraging them to actually control diabetes, that actually is also their job. It's not to say per endocrinology or per PCP. No, they should be doing it at every visit, just like we control hypertension. And same for obesity. I think it's time for us to start learning how to utilize some of these medications, such as GLP-1 agonists and some of the other medications as well, because obesity is also a major contributor to the progression of all kidney disease, but especially in people with diabetes.
Yeah. Thanks, Amy. Yeah, that's right on. And thank you, Kevin. I think you summed it up very nicely too. All right, well, I think now we have to challenge Dr. Argyropoulos to summarize this session today. And you all were introduced briefly to Christos Argyropoulos at the start of the meeting by Dr. Tuttle and Dr. Model, but he is at the University of New Mexico and a primary researcher and expert in diabetic kidney disease who can aptly summarize our meeting today and future challenges and future goals. So Christos, please take it away.
Thank you, Chip. So what I did during the meeting is try to get some slides and edit some slides that everybody before me presented, and this is gonna be my summary for the day. I believe that throughout the session, we all identified the challenges in managing DKD in primary care, challenges that stem from the difference in perspective, the fragmentations of the disease into separate problems as opposed to a single entity, and the asymptomatic nature. Unfortunately, if something doesn't hurt and something has a cost to treat, then you may not think of it as particularly significant, and you may pass on the opportunity for treatments. Many of the patients who come to our clinic are not aware that progression of the disease can now be modified. They only know of the two extremes, the normal and the dialysis. And in people who have had family members, and many of our patients with diabetic kidney disease do have family members on dialysis, they think that it's a destination that's predetermined and that nothing can be done about this. On the primary care side, despite significant knowledge of how to screen for diabetic kidney disease, and knowledge that you can treat it with ACE inhibitors, the actual treatment plans may be suboptimal. For example, ACE inhibitors and ARBs may not be maximized, and there is limited knowledge about the optimal time to refer. And this came out in multiple work groups, that what defines the optimal time of referral. We can often say after the fact that the patients should have been referred early, but we often say before the fact that why is the patient here in the nephrology clinic? So there's clearly some knowledge that needs to be generated to help everybody determine the optimal timing of referral. People do know about nephropathy as a complication and how blood pressure and diabetes contribute to nephropathy. But however, they don't seem to be aware about the renal replacement options, which often means that you will delay referral until very late in the process. there is clearly little appreciation that it's not just about the kidneys, and that management of kidney disease is managing of cardiovascular disease in patients with diabetes and vice versa. So many of the patients that are seen in primary care will often not survive to see a nephrologist or receive dialysis. So this is clearly something that we need to be communicating loud and clear, that with the newer agents, we can manage cardiac and renal disease and risk together. So how can we reduce diabetic kidney disease? We can continue helping the patients achieve glycemia, hypertension, and lifestyle management goals, but also tell them and inform them about the kidney status, what we have called know the numbers. So this know the numbers could be something as simple as the communication tool by the National Kidney Foundation, which I've actually used in studies of mine to tell people about their kidney status. Components of the office-based solutions to diabetic kidney disease is to see the patients frequently, rotate the themes of the visits, reinforce the multiple problems that can arise in patients with diabetes, and engage the patient throughout the way. How about medications? I believe the newer data kind of have simplified the management. I tell our fellows that diabetic kidney disease is actually very simple nowadays. You only have to use SGLT2s and GLP-1. So it doesn't take a lot of thinking. It's two classes of medications. Dose dependency for the cardiorenal outcomes is not there. In many aspects, it's a lot easier to use than ACE inhibitors, where you have to chase the dose. There are valid risk management strategies that can be applied, and they're very simple to educate people about and have them in the plan. I believe this slide just summarizes everything. So despite many of us non-diabetologists having being somewhat apprehensive about us using the medications, I believe they're actually fairly simple to use, and we just need to communicate to everybody how best we can do that. Having said all that, there are still significant barriers. We are dealing with a lot of information, a considerable lack of awareness about CKD, how we identified, how we treated, the historical avoidance of SGLT2 inhibitors in patients with low GFRs. For those of you who interact with me on the Twitter, we used to refer this as SGLT2 denialism. Definitely with something that can be very expensive medication and in a disease that requires a lot of interdisciplinary care, we are also running against the suboptimal care coordination. So for somebody who may be seeing a cardiologist, a nephrologist, a primary care endocrinologist, who is responsible to start the medication, to manage, to dose titrate them? So there's definitely a need for a team-based integrated care. And this is really the main strategy to improve the outcomes in patients with diabetes, with the medication just be tactics that we use. But we really need to strategize about coordinating care and empowering the patients while we are achieving some more medical goals that have to do with things like blood pressure, glycemia, initiating the therapies. Going back to the group questions, I believe the session, the last 40 minutes, we all identified very similar barriers and challenges in managing diabetic kidney disease in primary care, the fragmented healthcare system, the complex landscape that the patients have to navigate, the need for interdisciplinary care teams, which may be difficult to deliver outside large institutions. However, patients living in the community still need the same care, even though it won't be delivered by the same organization. It seems that things that are important is to engage navigators or patient support groups to help the patients understand the importance, have very clear, communicate very clearly to the patients why they're seeing a nephrologist, what is the potential outcome of the interaction with the nephrologist and the specialist. And speaking as a nephrologist, it's also very nice to know why I'm seeing a patient in a particular day. Often we get a very generic referral, with some set of labs. Generic referrals generate generic or boilerplate recommendations like avoid NSAIDs. So this dynamic, unfortunately, reinforces the notion that nephrologists cannot offer much, and on our side, it reinforces the notion that primary care physicians don't know what they're talking about. So this is really suboptimal when it comes to managing patients with diabetes. Seeing an increasing number of individuals with type 2 diabetes and chronic kidney disease in their adolescent years, and unfortunately we have had patients in their 60s and 70s in our region on dialysis because of type 2 diabetes, not type 1 diabetes. There is the need to generate more data and support our pediatric colleagues. Often drugs that are tested in adults may not be tested in children. The guidelines would lag, or the data will lag often a decade behind. And this is really a critical, important segment to reach out to. So I hope I did a pretty decent job in trying to summarize a very powerful and engaging session. And thanks everybody for being with us today.
Well, and thank you, Dr. Agaropoulos, for that wonderful wrap up, a summary of really the key messages and discussion of the day, and to all of our speakers, moderators, and participants. I guess I'll just wrap up by saying we, all of us as a community of stakeholders, patients, healthcare professionals across disciplines and specialties, are really obligated to let patients know not only of the urgency of this condition, but there is hope. We actually now can ring the alarm bell and say we have treatment, and it makes a difference. And it makes a difference in terms of saving lives and among the living, maintaining health. And that really should be our focus. And as one of the key deliverables, we will be writing a white paper following this meeting. It will also build upon the next strategy conference on June 16th, which will be a conversation with cardiologists and endocrinologists. And really, these white papers are enormously important. They guide policy that affects how we deliver clinical care, and importantly, how we resource it so we can do it right along the lines of what you all have talked about today. Around education, both for the communities, the public, patients, and professionals, with clear and simple messages about how to get the job done. And finally, it drives a research agenda. And as we progress, there will always be new questions. There will always be more knowledge needed. And we really need to embrace this concept while we're continually learning while doing and improving the care we deliver, because it really does matter. And finally, we can say, yes, there's urgency, but most importantly, there's hope. And so thank you all for being part of this, and look forward to ongoing work with all of you to get this job done. So thank you very much. And on behalf of the American Society of Nephrology and the Diabetic Kidney Disease Collaborative, I want to thank you all for joining us and staying for a few minutes after. So if you're on the East Coast, have a wonderful evening. For the rest of us, we can finish our workday.